Hello everyone. So today we are going to go with the pulmonary ventilation, one of the very important topic of the respiratory physiology. Pulmonary ventilations, okay? So what is meant by pulmonary ventilation? It is simply exchange of gases between the atmosphere and the lung by changing the pressure of the lung. Okay, we'll be dealing with this in detail. First of all, let's talk about respiration. So why do you think respiration occurs? Yes, respiration occurs in order to generate the energy. However, respiration are two types. One is known as external respiration, other is known as internal respiration. Internal respiration is a biochemical process in which the substrate they react with oxygen and produce carbon dioxide, water and energy. However, external respiration is actually the physiological process in which there is exchange of gases. The major goal of respiration is the exchange of gases, removal of carbon dioxide and intake of the oxygens. When we talk about respiration, we have different processes. The first of all, there is the exchange of gases between your lungs and the atmosphere, which is considered to be pulmonary ventilation. Then there is the transport of gases or exchange of gases between the alveoli and your blood. And from there, the oxygen, carbon dioxide, they are transported to different organs. Yes, if the carbon dioxide is there, it is transported towards the lung. If there is oxygen there, it's transported towards the tissues, and in the tissues as well, there is exchange of gases. So these are different steps of our respiration. And today we are dealing with the pulmonary ventilations. Now, most importantly, if we know that in physics, air move from the higher pressure to the lower pressure. If you want to make your air move from the atmospheric region to your lung, the pressure in the atmospheric region should be greater than that in comparison to that of the lungs. Right? We know that air, this is very important, air moves from higher to the lower pressure. Because of that reason, atmospheric pressure should be higher and intra-alveolar pressure or the pressure of the lung should be lower in order to make sure that the air move from atmosphere to the alveoli during inspirations. We cannot change the atmospheric pressure, however, we have to change the intra-alveolar pressure. In order to change the intra-alveolar pressure, how can we change it? We know that PV is equal to constant. That means volume is inversely proportional to pressure or pressure is inversely proportional to volume. If you want to decrease the pressure, you have to increase the volume. So, to inspiration, you have to increase the volume of the lung. In order to increase the volume of the lung, you have to increase the volume of your thoracic cavity altogether, and in that place comes our inspiratory muscle. We have two types of inspiratory muscle. One is considered to be primary inspiratory muscle, other is considered to be secondary inspiratory muscle. Primary inspiratory muscle come into action even in the context of passive inspiration. However, secondary inspiratory muscles comes only in the context of the forced inspiration. Primary inspiratory muscle, we have diaphragm. About 75% of the volume change is caused by the diaphragm. One of the most important muscle, if the diaphragm gets paralyzed, what happens to the individual? We'll be talking about that as well. What does diaphragm do? Diaphragm is dome shaped in the normal condition. When it contracts, it becomes less dome shaped and increase the thoracic volume vertically. Diaphragm has two fibers. Specially, one is considered to be costal fiber, other is considered to be crural fiber. They insert into the central tendon. Central tendon is the projection that comes from the pericardium. When these fibers, costal fibers and crural fibers contract, the vertical diameter of the thoracic cavity increases. Along with that, oesophagus closes. However, during emesis, you want to create the intra-abdominal pressure higher. In that case, you have to contract the diaphragm. However, due to the contraction of crural fiber, oesophagus closes. So, clostridial fiber only contract. However, crural fiber does not contract during emesis, which is very important thing to remember. Now, after diaphragm, we have external intercostal muscle. External intercostal muscles is also very important muscle. It is present externally and between the two ribs. It pulls the rib forward and outward. It has two movements. One is considered to be bucket handle movement and the other is considered to be pump handle movement. Like the handle of the bucket moves laterally, it increases the lateral diameter. It works for the 2 to 10 ribs, 2nd to 10th rib. Pump handle, it increases the antero-posterior diameter and it works in the first 4 ribs. If diaphragm gets damaged, we know that the nerve is C3 to C5. If the diaphragm gets damaged or the diaphragm gets paralyzed, and in that case, external intercostal only can also help in survival of the person. However, the person suffer from dyspnea and breathlessness very easily. Diaphragm, the intervention is, we know that C3 to C5. So if you do spinal transections above this level, then the person die. If the diaphragm gets paralyzed unilaterally, then the movement is opposite of that reason in comparison to the normal condition. For example, if the diaphragm here is paralyzed, then in that case, during inspiration it moves upward and during expiration it moves downwards, which is a paradoxical movement of the diaphragm. Except for that, in the secondary, we have sternocleidomastoid, scalene muscle which is present in the first 2 rib, other muscles of the back and the neck as well, including digastric muscles, omohyoid muscles and a lot of things. They are only responsible for the first inspiration. What happened? The volume of the thoracic cavity increased because of these muscles. As the volume of the thoracic cavity increased, what happens? The lung gets pulled forward. How? For that, there comes another concept. We have to know that lung is surrounded by pleura. Within the pleura, there is presence of pleural fluid. Pleural fluid is continuously produced and continuously absorbed by the lymphatic drainage. Because of the lymphatic drainage, it creates vacuum, and because of that reason, there is a suctioning force for the lungs, preventing the lungs to collapse. Therefore, pleural pressure is always negative. And because of the internal recoil capacity of the lung or tendency of the lung to recoil internally and the tendency of thoracic cavity to recoil externally, the pressure in the pleural fluid is negative. Now, because thoracic cavity expands, the pleural fluid becomes more negative as vacuum is created, and because of that reason, the lungs get pulled more. And there plays a very important role of a pressure which is considered to be transpulmonary pressure. Okay, so there comes a very important pressure which is considered to be transmural pressure. Transmural pressure means transpulmonary pressure and trans-airway pressure. Pulmonary pressure means the pressure difference across the wall of alveoli, means pressure difference between the intraalveolar pressure and the pleural pressure. We know that bronchioles, they do not have cartilage. So something that prevents it from collapsing is the airway pressure itself. So trans airway pressure is the pressure difference across the bronchiolar wall between the intrabronchial lumen and the intrapleural pressure, and they are always positive. As the lung expand, this transmural pressure they increases. As they increases, the lung expand. Now let's talk about expiration. For the expiration, the pressure inside the alveoli or pressure inside the lung should be greater than that of the atmospheric pressure. For that, the volume of the alveoli should decrease. In order to decrease the volume of the alveoli, the volume of the thoracic cavity must decrease. So let's talk about muscles of expiration. In normal condition, expiration is carried out passively. The recoil of the lung, thoracic cavity and the relaxation of the inspiratory muscle is enough to cause the expiration. However, during forced expiration and in the diseased conditions, especially during emphysema, the expiration becomes active process, and in that case we have internal intercostal muscle and abdominal muscles. In abdominal muscles, we have transverse abdominalis and rectus abdominalis. Okay, so these are the muscles along with the muscles of our neck and the back as well. Now talking about internal intercostal muscle, it pulls the ribs backward and downwards. Abdominal muscles, it pushes the diaphragm more and create more dome cell in order to help the lung to expire. The most important thing about this is inspiratory muscle helps to increase the diameter of the lung. However, expiratory muscle, it actually helps in avoiding the air resistance or decreasing the air resistance altogether. Now, I'll be talking about one of the very important topic which is considered to be compliance. Compliance means when the transpulmonary pressure changes, how much volume of the lung changes. Del V divided by del P. Now, this compliance of a normal lungs is about 200 milliliter per centimeter of H2O. However, inside the thoracic cavity, because of the resistance, it is 110 milliliter per centimeter of H2O. We have to know that the change in the transpulmonary pressure, if it is just 1 centimeter of H2O, it is enough to inspire as well as expire. Tidal volume, which is 500 milliliter. Okay, so that is also something we cannot forget. Now, compliance of the lung means it is about how the lung compile or how the lung tends to change the volume when the transpulmonary pressure is changed. Compliance, we have two types of compliance. One is considered to be static compliance and other is considered to be dynamic compliance. Static compliance is the compliance of the lungs when the airflow is not there. And dynamic compliance is the compliance of the lungs when the airflow is there. Because air resistance plays very important role during dynamic compliance, it is lesser in comparison to that of the static compliance. Now, compliance is very different for the expiration as well as inspirations. If we see this graph, we need to know that the expiratory compliance goes in this way. This volume pressure graph. And inspiratory goes in this way. This is expiratory, this is inspiratory. So this is very confusing. There is a hysteresis loop present here, right? So see, before we move towards the interpretation of this graph, first of all we should understand that the compliance of the lungs is determined by two things. One is considered to be elastic capacity of the lung and other is considered to be the surface tension of the lung. Elastic capacity is just for like 1/3. However, surface tension is for the 2/3 determination of the compliance. Which shows Now, elasticity. So, what are the conditions in which compliance changes? Okay, if the elasticity is affected, mostly the compliance changes. The first, fibrosis. During fibrosis, the lung cannot expand properly. As the lung cannot expand properly, the functional ventilation capacity decreases and compliance also decreases because lungs cannot expand properly. And during emphysema, as the elastic tissues are damaged and the lung can get expanded properly. So in emphysema, the functional ventilatory capacity, it increases, and hence the compliance also increases because lack of elastic tissue, the lung gets expanded easily. Talking about this elastic capacity, it is due to elastic tissue and due to the collagen fibers. Collagen fiber resists the expansion of the lung, and elastic fibers, it allows the expansion of the lung. If the lung is expanded for a long period of time, it becomes saggy. Now, I'll be talking about the elasticity and surface tension in the next video. But right now, we are going to talk about the interpretation of the graph, which determines the expiratory compliance and the inspiratory compliance. Compliance can be determined by the slope. This is a slope, this is a slope, this is a slope, and this is a slope. As we can see that during expiration, the slope is getting flatter and flatter and flatter, which means compliance is decreasing during expiration. What is the reason for that? The major reason is during expirations, first time, because of the elastic recoil, the lung gets contracted faster and the change in volume is more because of the elastic capacity. But as the expiration progresses, some of the alveoli, they collapse. So only few of the alveoli, their volume changes. So that's the reason why expiratory compliance decreases with change in pressure. Now, talking about the inspiratory compliance, we can see that it's getting steeper and steeper and steeper. That means inspiratory compliance increases as we inspire. Why? Because at first, some of the alveoli are collapsed and it takes more pressure in order to open those alveoli. But as the inspiration progresses, most of the alveoli are already open, so it's easier to enlarge the alveoli. Every alveoli, they do not collapse, and for that we have very important topic, which is surfactant. We'll be dealing that in the next class.